Welcome to The Explainer. Today, we're talking about something that affects millions of people, but is often, kind of confusing: uterine fibroids. We're going to cut through all that noise and give you a really clear, empowering guide to what they are, why they happen, and what your options actually are. All right, let's dive in.
So let's just start with a question. What is a common, non-cancerous growth that a whopping 80% of women may have by the time they hit 50? Seriously, think about that number, 80%. The answer might surprise you. And the answer is a uterine fibroid. Now, I know the word tumor can sound pretty scary, but here is the single most important thing to remember. Fibroids are benign. That means they are not cancerous. In fact, they are the most common benign tumor in the female reproductive system. So let's just get that out of the way right now. Okay, so with that in mind, let's get down to the fundamentals. What exactly is a fibroid, and where do they even come from in the first place? Well, this timeline tells a really fascinating story. You see, fibroid growth is pretty much fueled by hormones, especially estrogen. And that's why this all makes sense. They're super rare before puberty, then they become common during the reproductive years, say from 30 to 50, and they can even get bigger during pregnancy when hormones just surge. And then, what happens after menopause? Estrogen levels drop, and the fibroids typically shrink. This hormonal link, it's the absolute key to understanding the whole thing.
So yeah, that hormone connection is the biggest risk factor, which you see right there at the top. But other things definitely play a role too. Genetics are a big one. If it runs in your family, your risk goes up. Lifestyle factors also matter, like starting your period at a young age, obesity, or a diet high in red meat, because these things can all influence your hormone levels. It's also really well documented that women of African origin have a higher incidence, which is a complex issue researchers are still working to fully understand. So we know what they are and kind of what causes them, but how do you know if you actually have them? Well, it turns out it all comes down to one thing: location, location, location. Before we get into all the technical names, I've got a great little memory trick for you to keep the types straight. Just remember these 4 words: inside, wall; outside, stalk. It's a super simple phrase that perfectly maps onto the 4 main places fibroids can grow. And here's that little trick in action. A submucosal fibroid is inside the uterine cavity, and because it's right there in the lining, it's often the one that causes the most trouble. We're talking heavy bleeding and even fertility issues. An intramural one is inside the muscular wall of the uterus, and that's actually the most common type. Subserosal fibroids are on the outside of the uterus, where they can push on your bladder or bowels. And finally, you've got pedunculated fibroids, which grow on a stalk and can actually twist, which causes this sudden, sharp pain. See? Location is everything. But here is probably the most surprising part of this whole explainer. After hearing about all those potential symptoms, the reality is that about half, 50%, of all people with fibroids have no symptoms at all. They're completely asymptomatic. Millions of people are walking around with them and have absolutely no idea. Now, for the other half who do have symptoms, the body can send some pretty clear signals. The number one complaint is heavy or really long periods. But again, depending on where that fibroid is, you might feel pelvic pressure or like you have to pee all the time if it's pressing on your bladder, maybe constipation from pressure on the bowel, and in some cases, it can even interfere with fertility. So, if you're experiencing some of these things and you're thinking, maybe this is me, what's the next step? Let's walk through how fibroids are officially diagnosed. Don't worry, the process is actually pretty straightforward. The path to a diagnosis usually starts with a simple clinical exam. A doctor might be able to feel that the uterus is a little enlarged or has an irregular shape. From there, the key next step is almost always a pelvic ultrasound, which just uses sound waves to create a really clear picture. Sometimes, a doctor might want an MRI for more detail, or maybe some blood work to check for anemia if there's been a lot of heavy bleeding. But of all those different methods, the pelvic ultrasound is truly considered the gold standard. And why is that? Well, because it's non-invasive, it's widely available, and it's just incredibly good at identifying the size, number, and location of any fibroids. It gives doctors pretty much all the essential info they need. Okay, so you have a diagnosis. Now what? This brings us to our last and honestly most important section: management. Because getting a diagnosis does not automatically mean you need some major surgery. There are a lot of different pathways. So this is the crucial point right here. There is no single best treatment for everyone. The right approach is deeply, deeply personal. It's a conversation that you have with your doctor, where you weigh everything, your symptoms, the size of your fibroids, your age, and, this one is very important, whether or not you might want to have children in the future.
Generally, your options fall into a few main buckets. For a lot of people without symptoms, the best choice is just observation, or what doctors call watchful waiting. For others, medications can help manage symptoms like bleeding or pain. Then, of course, there are surgical options, which we'll get to in just a sec. And finally, there are newer, less invasive procedures, like uterine artery embolization, which basically works by cutting off the blood supply to the fibroids, which causes them to shrink.
Now, when surgery is the chosen path, there are two main choices, and the difference is critical. A myomectomy is a procedure that removes only the fibroids, leaving the uterus intact. This preserves your ability to have children. A hysterectomy, on the other hand, removes the entire uterus. It's a definitive, permanent fix for fibroids, for sure, but it also means pregnancy is no longer possible. This is a huge distinction that really comes down to your personal life goals.
Whew, we have covered a lot today, from what fibroids are all the way to how they're managed. They are incredibly common, but as we've seen, the path forward is totally unique for every single person. So that leaves us with one last thought. Now that you know all of this, what's the right first question you should ask your doctor to start the conversation that is right for you?